I'm Dr. Derek Lee. It's my pleasure to introduce Dr. Isador Izzy Lieberman. He's an orthopedic and spinal surgeon who was a past president and is the current director of Scoliosis and Spine Tumor Program at the Texas Back Institute. Dr. Lieberman specializes in the surgical treatment of spinal disorders, including adolescent and adult scoliosis, deformity reconstruction, minimally invasive endoscopic spinal surgery, cervical and lumbar degenerative disorders, including herniated discs, spinal stenosis, spinal tumors, infections, and trauma. Dr. Lieberman's research interests include clinical outcomes in spinal surgery, biomechanics of spinal implants, robotics for spinal surgery, gait analysis, and disc replacement technologies, which I want to talk to you a little bit more about. He has conceived and developed a number of spinal surgery instruments and implants and has over 30 issued U.S. patents. He has over 140 peer-reviewed publications and over 50 book chapters to his credit. He has presented over 200 invited lectures at universities, hospitals, national meetings, and international meetings. Welcome, sir. And it's an honor to talk to you today.
Thank you very much, Derek. The privilege and pleasure is mine, and whatever information that we can disseminate this morning that's going to help our patients, our families, and selfishly, I know I may need some of this treatment in the future, help those coming behind us to do even better, will help all of us.
Now, what's interesting is you treat both adolescent and adult scoliosis.
Correct. Yep.
Is your practice primarily one or the other, or is it kind of equal on both?
It's primarily adult. About, I'd say 25 to 30% of the practice is adolescent, pediatric, scoli. The rest is adult degenerative, adult deformity, and tumor. I do a lot of work overseas as well. The work I do in Africa and Uganda is almost exclusively adolescent deformity or infection and TB. So it's a difference. So the 2 weeks I'm in Uganda, it's all kid stuff. It's pretty much all individuals under the age of 20 that we're taking care of there. But here in North America, the practice is about 25 to 30% kids, and the rest is adults. And kids, I mean anyone under the age of 20.
Now, with the adults, is it primarily, or what percentage is it adolescent idiopathic scoliosis who have had surgery before or haven't had surgery? And what percentage would you say is adult degenerative in nature?
So the vast majority is going to be adult degenerative, meaning curves that are later in onset, come on somewhere between the ages of 40, 50. They're unnoticed till they're 60, till they become symptomatic. And then they become debilitating for a number of reasons that I'm sure we're going to get to in their 60s and 70s that require one form or another form of treatment. So that's the vast majority of what I see. The adolescents and pediatric kids that I see, a lot of them is just observation. It really is. But we've got a lot of spinal asymmetries that never go anywhere. But I enjoy interacting with them. I enjoy interacting with the families. We have fun. They come, they visit, they tell me about their sports, their travel. It's a good thing. But the majority of those are observational patients. Less than 10% of the adolescent or kids or the adolescent idiopathics that I see come to any kind of surgical intervention, and probably a third of them go on to some kind of bracing intervention.
Excellent. Now, over the years, have you noticed any trends in terms of post-surgery adolescent idiopathic scoliosis, how their outcomes are over the next 10, 20, 30 years?
Yeah, lots of changes. Today, we're in a very privileged position as spinal surgeons. There's so much technology on the shelf. There's so much information available to us. Our job is to figure out how to use that information to the benefit of our patient today. I know what I am doing today, 10 years ago and 20 years ago, was science fiction. There was no way we thought we'd be doing what we're doing today. I also know 10 years and 20 years from now, those that I teach and those that are following me are going to look back and say, wow, what Lieberman did was pretty primitive at that point in time. The technology is there. So yes, to answer the question, there have been changes from the first instrumentations, the first bracing, the first exercise programs. We've learned so much about muscle flexibility, about stamina, about physiologic balance, about bone physiology, bone growth, instrumentation, alignment, going on, that yes, things have changed and things have changed for the better. We know that we want to limit, if they come to surgery, we want to limit what we operate on. We want to minimize the collateral tissue damage. We want to do everything we absolutely have to do, but not one bit more than what we need to do. And the need to do is achieve, optimize function, and maintain balance. That's the key, whether you're dealing with adolescents or adults. But the knowledge we've gotten in achieving balance and maintaining function has changed the outcomes today.
Function and balance. It seems to me that, and spine surgeons would admit it, that previously they used to be focused much more on curve corrections, for instance, AIS, and even adult scoliosis, to max correction to zero possible, with adding more levels to, for instance, posterior spinal fusion and limiting function as a result. And it seems to be going in the other direction now. Is that part of the function and balance scenario?
Oh, yeah. Yeah, absolutely. Because function is directly related to motion. Motion is directly related to discs, to joints, to muscle activity. Muscles are the actuators, the discs are the modulators and the facet joints, and the ligaments are the restrictors to those various motions. We know as soon as we intervene as surgeons, we're altering the natural course of things. I use an example with my patients. I tell them to think of your spine like a train on a track. You've got the engine, the caboose, and all the cars in the middle. If one of those cars in the middle is pulled off the track, something happens to the engine and caboose. If you put that middle car back on the track, everything lines up and rolls again. If one of the wheels falls off a middle car on the track, you're going to feel that all the way up and down the train. If one of those wheels isn't turning, it's grinding along, you're going to feel that all the way up and down the train. So as soon as you think about it in that fashion, you understand, yeah, it's all connected. And in that way, we optimize function by minimizing our intervention to where we absolutely have to.
But it sounds like you're always thinking about function first and balance in terms of trying to reduce levels fused or having minimally invasive surgeries, that type of thing, right? With your patients over the last 10 to 20 years or so, starting with AIS, how have the patients responded to those surgeries? Have you had issues with adding on levels? Has there been proximal junction kyphosis complications? What have you noticed with your patients over that period of time?
So I'm going to divide the answer into the adolescents and into the adults. The adolescent curves function has been very, very good. I've got high-level athletes. I've got Olympic athletes that are back doing what they're doing after I have optimally aligned their spines to prevent progression, to avoid some of the discomfort they're having, doing it in the least invasive, most appropriate way. So function is improved. Long-term outcome has been very good. Very few come back for adjacent segment issues. Very few come back for pseudarthrosis, where the bone hasn't healed, or rods, screws, pull out, breakage, because we've got the spine biomechanically aligned, so function's maintained, so they're doing what they need to do. So in the adolescent group, the outcomes have been predictable and very, very good. Now, we still have to wait. I'm fully well aware that tomorrow, nobody is going to be as healthy as they were yesterday. Things deteriorate. I intervene on a spine on a patient that's 14 years old. At some point, they're going to have problems at the levels above and below, whether that's 10 years out or 20 years out. And I've been doing this 33 years now. I'm seeing very, very few of those patients come back. 40 years from now, 50 years from now, yeah, they're going to have arthritic changes at those adjacent levels. But I've given them 30 or 40 years of pretty darn good function with a balanced spine. So that's the trade-offs that you get. And leaving those curves untreated, I can't tell with 100% certainty where they'd be, but I'd like to justify my own existence and say they'd probably be worse off. So that's the adolescent group. The adult group is a different phenomenon. And one of the issues that we haven't yet brought up in the adult group is the neurological symptoms as well. Very often with adult degenerative scoliosis, you're getting nerve root compression, you're getting spinal cord tension, you're getting spinal cord compression, which results in what we call radiculopathy or myelopathy, where the spinal cord's being compressed or irritated, the nerves are compressed or irritated, and the signal can't get from the brain to the big toe, which manifests as neurological pain, as some kind of muscle weakness, and some kind of sensory disturbance. That of itself is a trigger to consider surgical intervention. Now, yes, we exhaust all the non-operative treatments, but when we see that neurological component in the adult degeneratives, we typically are obliged to intervene. So going back to function and alignment, in the adult degeneratives, we have to consider the neurological component to it. Frequently, very, very often, the neurological component dictates a much more extensive procedure. It's just the reality of it. I have to make more room for the nerves. I have to pay more attention to realigning the spine. Sometimes areas of the spine have gone on to fuse themselves, or the bones have become misshapen. So I have to rely on some basic carpentry to realign the spine, to get things where they need to be for function and motion. And then we look at the balance, and I know I have directly or indirectly made more room for the nerves to alleviate the neurological symptoms. Now, older patients don't recover as well. Older patients also have stiff hips, stiff shoulders, bad knees. Going back to the train on a track analogy, you've got the engine and the caboose and everything in the middle, where somewhere in the middle, you've got your hips, your knees, your shoulders, your neck. All of that stuff then compounds the outcome of the adult degenerative. Adult degenerative, as good as I like to think I am, I'm still not good enough. Yes, I do run into problems at the top end of constructs, at the bottom end of constructs. Yes, bone is weak, it's osteoporotic, it doesn't hold, I have to use cement. A lot of the time, I am doing this more with a heuristic trial and error approach without the scientific basis. I'm adjusting this, adjusting that on intuition more than on true knowledge of what the biomechanics is and how my intervention is going to affect that. But that's how we learn. And learning that way, I'll never, ever get it perfect. But each time I go at it, I'm a tiny bit better, a tiny bit better. So the next patient's going to have a tiny bit more of my experience to help in their outcome.
Well, there's so many variables to try and juggle with each individual patient that it's daunting, actually. But I think you thrive on daunting.
All right. Yeah, I like that. I thrive on daunting. Good. I'm going to keep that one in the books.
Okay. There's a t-shirt in the mail for you there.
Thank you.
Based upon your comments, if there's any neurological deficits or symptoms, that's perhaps the time when an adult should be at the beginning stages of considering surgery at that point.
The key word that you just said was considering. Nobody absolutely has to have an operation. You consider it and you base your decision on risks versus benefits. All comers to surgery, to spine surgery, there's an overall 10% risk rate. Now, depending on those daunting variables that you just mentioned, the risk rate can go up to 20%, to 30%. My personal cutoff when I'm talking to a patient, if I estimate that their risk rate is above 30%, I tell them up front, I in good faith, cannot recommend to you to have an operation. I feel the risk rate is too high. I don't feel I can get you through it safely enough. Infections, heart attacks, strokes, blood clots, pneumonias, your diabetes, your poor bone, your general conditioning, your bad hips, your bad knees, you've had 3 previous strokes, all of those things up that 30% risk rate, where at that point, it's not feasible. And you base your decision on the downside, not on the upside. Everyone says, well, it's a 30% risk of not doing well, but I have a 70% risk of doing good. I said, no, it doesn't work that way. 30% downside. It's like you're making an investment on the stock market. If you know you've got a 30% chance of losing that investment, are you going to take that investment, even though you may make 5% on the rest of it? Doesn't work that way. And this is where we transition to some of the non-operative treatments, bracing for one, medications, 2, consistent and persistent exercise programs, 3, looking at all of those things in combination, working on bone health and bone quality, and also on behavioral health, getting in the right frame of mind, understanding, yeah, the train is not on the track. This is what I have to work with. Find out a way to work with it. So those are the things that we look at. And we're learning so much more about the value of bracing and of exercise right now. We've been hung up on the negatives of those. Exercise, well, I go to therapy, it makes me worse, it's this, it's that, then I don't go for 4 weeks. That doesn't help you. You've got to be persistent. Consistent bracing, we know, weakens the muscles, weakens the bones. Yeah, it's going to make them feel better, but that's not the right answer. The answer is the dynamic type bracing combined with exercises where you maintain muscle mass, you maintain function. That's where you improve. You're not fixing the underlying degenerative scoli. You're not relieving the stenotic, the radicular, or the myelopathic symptoms, but you're improving function with those types of modalities.
If we dive into that a bit more, because I totally agree, patients will get turned off with movement and exercise because it hurts, but they do have to realize they have to sacrifice or understand that their body is being pushed. They have to understand that they're going to feel it and persist to get through it. Now, with respect to dynamic bracing, what kind of bracing are you talking about specifically?
So there's a number of braces that are available now, and there's a lot of work that's coming out now because we, again, understand balance and function. Now, in the spirit of disclosure, I'm involved with a company called Green Sun. We're making a dynamic brace that applies consistent forces throughout the full range of motion. So you've got the corrective forces to support the spine, but the brace moves with you, as opposed to a static brace that just holds you there, can apply corrective forces, but your muscles aren't doing the work. Your bones aren't doing the work. The brace is doing the work. You lose. You're not gaining. The whole principle of exercise is, yes, to push yourself, but you have to allow the recovery. If you don't allow the recovery, you don't build. You don't build. And what often happens is people push themselves, they're painful, they don't do something for 4 weeks, and they don't build. They don't gain from that. So you got to push, recover, push, recover. Ask any athlete, push, recover, push, recover. And this is where the dynamic bracing helps, because it allows you to push. And while you're recovering, you're maintaining the muscle activity, you're maintaining the balance, you're recovering. The neural networks in your brain are being reprogrammed. The muscle balance is being reprogrammed. And I'm a big fan of Pilates type exercises. And again, in the spirit of disclosures, I've got a daughter who's a Pilates instructor. She's absolutely fabulous. I send her a ton of my patients. But it's remarkable to see with consistency the improvements that these patients can make. And it gets back to what we were talking about before we started the recording. Don't look at the x-rays. Look at how the patient's functioning. Listen to what the patients are telling you. Before I started Pilates, I couldn't sit for 5 minutes. I couldn't walk for 10 minutes. Now, I've been doing Pilates consistently for 6 months. I can go to a movie. I sit there for 2 hours now. Am I comfortable? No, I'm not that comfortable. I can do it. I can now walk 3 miles. Does it bother me? Yeah, but does it hurt? No, it doesn't hurt. Function. That's where we're at. And that's where dynamic bracing can augment the function. That's the aid to optimize the push recovery cycle.
Excellent answer. If we can dive a little bit into surgery for adult scoliosis. Your adult scoliosis patients are from the degenerative scoliosis demographic. With respect to adolescents, parents are always looking, and kids are always looking for non-fusion types of surgery, again, for function. With VBT, vertebral body tethering, there are many adults who are interested in that because they don't want to have fusion. What's your opinion on that as an adolescent and an adult procedure?
Complicated answer. Very complicated topic. Very complicated answer. You're asking me to cover everything that I think I've learned in the last 30 years, the sort of universe of knowledge. I know what I know. I know what I don't know. And the dangerous part is I don't know what I don't know. But we talked earlier about function, balance, the indications to consider in operation. Now what we have to talk about is doing the right operation the right way for the right reasons. And I label this symptom-specific surgery. Whether it's an adolescent or an adult, it's the same principles. Why are you doing the surgery? What are the symptoms? How do you relieve the symptoms? How do you optimize function? How do you maintain appropriate balance? Those are the things that you need to look at. And there are so many tools in our toolbox right now, which is what puts us in this privileged position. I've gone on record as saying the decision is far more important than the incision. So the decision to have the operation and what is the right operation are the critical things. Now, there are other variables. Execution. Yeah, there are great, great surgeons out there that can operate standing on one leg with one hand tied behind their back with one eye closed and still get brilliant results. And then there's the others that don't get such good results. But you've got to come to the operating room with a plan to know what you need to do to address the symptoms, whether they're adolescents or adults. Now, in the adult group, and that's where you want me to focus now. So the indication for me to operate on an adult is unrelenting pain that can either be mechanical or neurological, disability in function, and progression of deformity, which amplifies the disability in function and the pain. So if I've checked off those three boxes, I'm going to recommend an operation. Then I have to decide, what is the operation? Tethering in the adolescent and the adult group. And I've gone on record with this, and I'll say it here on this podcast. I don't feel it's the right answer. It's not the right answer. We have to remember that the deformity is a three-dimensional deformity. There's rotation, translation, and collapse. And when you have all that, putting in a tether doesn't address all three of those and alters the biomechanics. So let's go back to the train on a track analogy. Okay. The train is off the track. You want to try to put the train back on the track. So you take jacks and you jack up three of the cars up in the air. Is the train back on the track? No. All you've done is change the biomechanical alignment. And what I'm seeing in the adolescent group, and this is personal experience, and I have not tethered anybody, but I do have right now in my practice 3 young patients that have been tethered elsewhere that live in my community that I follow. And yeah, the middle curve looks okay. The tether curve looks okay. But they develop these bizarre curvatures above and below because we've altered the biomechanics and the brain can't anticipate what is going on. I said the brain sacrifices alignment for balance. The brain doesn't know that the spine is tethered and fixed in that alignment. It's trying to balance itself and it's trying to figure out where the balance point is. And you only have so many levels it can move. So we see these bizarre curves because we've changed the biomechanics in one plane with a tether, trying to rely on growth in these kids when they really don't have that predictable growth to compensate. So that's my philosophy on the adolescent side. On the adult side, tethering is absolutely not indicated. No, end of discussion. The discs are degenerative. There's no growth potential. The facet joints are degenerative. It makes no biomechanical sense whatsoever. Now, having said that, interestingly enough, just yesterday, I was one of the guest speakers at the Seattle Science Foundation Motion Preservation in Spine, and they asked myself and 2 other deformity surgeons to talk about motion in degenerative scoliosis. And we were concentrating particularly on the fractional curve. Universally, all 3 of us said, we need to come up with a solution for motion because we know fusion's not the right thing. So is this a disc replacement? Is this a modulation device? Is this some way to realign? And I don't want to use the word artificial because it's just been overused lately, this artificial work, but some way to still maintain motion without fusing, without locking the biomechanics. So let's go back to the train off the track with the jacks up in the air. What we want to do is put those cars that are off the track back up on jacks, but not jacks, hydraulic shock absorbers of some sort. Something that we can get the train cars back on the track to maintain function and alignment. And that's what the next generation of spine surgery is going to bring to us for the adult degenerative scoli patients.
What's the timeline for that, do you think?
It all depends on the FDA. It all depends on how many people subscribe to this same philosophy that motion is appropriate. And then when we finally do get the right thing, is the FDA going to approve it? Is the government and the insurers going to pay for it? Are surgeons going to adopt it? There's just, this is not an overnight. It's not a light switch. It's not on off. This is an evolution. Look at spine surgery from the history of pedicle screws in the 80s to today. It's going to be another 30, 40 years easily. It's not going to be in my lifetime as a spine surgeon.
I am aware of some surgeons, specifically in Europe, who are using or trying to use artificial discs
Yep.
for even adult degenerative scoliosis. It seems to be a combination of cages, artificial discs, fusion, pseudofusion, that type of thing. Do you have any insight into that?
Yeah. And one of those surgeons was on the meeting with us yesterday, just a giant in our field. And I'm allowed to mention names, right?
Of course.
Terry Marnay, who's been a giant, great thinker, great surgeon, doing things and showing examples of that. And very scientific about it as well, which is critical. That's the key thing, to be critical about what you're doing and consistently evaluate what you're doing to make sure you're doing it right. It is the way to go. We just have to figure it out. And the guys in Europe are much more forward thinking than we are in terms of looking at alternatives. And another aspect in Europe, they're not as influenced by the marketing. They're able to think a little bit more critically and do that. So yeah, I would welcome the ability to start using some kind of motion preserving devices at the bottom ends of some of my scoliotic curves, so I don't have to lock them to the pelvis. But I don't have access to the disc replacements that we need. There's specific disc replacements that will function well in that field, but some won't. Insurance companies won't pay for it. So the patients are, ooh, this is going to cost me how much money? And there's just a number of different variables that are obstacles, are hurdles in our path in North America now to really look at that critically at this point in time.
What have been the greatest innovations within the last 10 years?
So it's not as much an innovation as a recognition of the importance of alignment. But what we haven't yet looked at critically enough is patient-specific functional alignment. We're talking about alignment parameters and gap scores and PILL mismatch. That's pelvic incidence lumbar lordosis mismatch. In life, there are lumpers and splitters. The lumpers, this is the way it should be, straight, boom, done. The splitters, well, we need this angle here, we need this angle here, we need this over here, we need this over. But really what we should be looking at is function. A patient that stands more during the day than sits more during the day needs more lumbar lordosis to keep the head centered over the pelvis. And just think about it. When you're sitting in your chair, what are you doing? You're flattening your lumbar lordosis. Nobody wants to sit with a really arched back. That becomes uncomfortable. When we fuse someone in that position, we ask them to sit. What does the brain do? The brain sacrifices alignment to maintain balance. When you're sitting like this, you're not balanced. What do? You bend forward. When you bend forward, you get a proximal junctional kyphosis over time. That's what happens. So this is where, and this is the era that we're now getting into with predictive analytics, with this AI type work. And again, in the spirit of disclosure, I'm very involved in a lot of the predictive analytics and AI for spinal surgery right now, where we're looking at the patient's anthropometric data, demographic data, functional data, imaging data, and then devising on the basis of biomechanics the most appropriate surgical recipe for that patient. And that recipe may be motion device at the 3-4 level and the 5-1 level, with fusion at 4-5 and fusion at 2-3 and 1-2, in order to get that appropriate functional balance for that 72-year-young osteoporotic female who still wants to play pickleball, but yeah, she's at home most of the day sitting on her couch. That's the way we have to look at these patients now. And that's how we have to devise the most appropriate surgical intervention. And you saw I weaved into there the function with motion allowing or motion modulating devices and the biomechanics and predictive analytics to define what is the most appropriate.
Do you find that even with, for instance, your early data, that the AI recipe for predictive surgical levels, et cetera, does that kind of jive with what you're already doing, or are you finding any surprises?
I can't answer that yet. We're so early into it, and I don't want to be misleading. Intuitively, I think, yeah, absolutely, that makes sense. But look at what's happening with Chat GPT today. Everyone's running to it, and they're not quite getting the right answers all the time, are they? So I don't want to go there yet. We're in the basis of development. We're building out databases. We're doing retrospective training of the software algorithms because we know what the outcome is. If we retrospective train on that, we may be able to find the trends and learn from those trends so that the next prospective, we can say, oh, this matches the trends. Here we are. This is what to expect as the outcome. That's where we're at today. That's all I can say
Mhm.
legitimately today.
Okay. Just to jump off track, so to speak, on a train analogy, for patients that you see who've had previous surgeries, not necessarily by yourself, and perhaps their initial surgeries were the most corrective in terms of function and balance, and they're having issues as they age, how do you determine whether or not surgery is an option?
So every Tuesday, I spend my day in the penalty box. I don't know if you ever played hockey, but the penalty box, if you're a hockey player, the penalty box, you got to go sit there. You got your stick between your legs. You're serving a 2-minute minor or a 10-minute major. And when you're in the penalty box, all the fans can throw stuff at you. They can shout expletives at you, but you cannot lash back. You have to just sit there, wait, take it until you get back on the ice. So that's my Tuesday. That's the penalty box. That's me in the clinic. When I'm in the penalty box and I look around, the first thing that pops into my mind when I see that patient, can I fix that patient or not? It's just me looking at them. And I can tell the look on their face, the way they're sitting. Did they bring their suitcase in with them? Do they have 15 other people in the room all facilitating their disability? Or is this person sitting there, right? And you can tell they're in pain, but doc, I'm in pain, but I need to get better and I can't get better. I want to get better. You just look at them and you just know right away, this is someone I can fix. This is someone I can't fix. So that's the first hurdle. Once I determine that this is someone I can't fix, that's the toughest part of my day, explaining to them why I can't fix your problem. And yes, they leave upset at me. Yes, they go right to the internet and put these terrible reviews on me and Google star ratings of 2s and 3s because I was transparent and open and honest with them and telling them, you're not in good shape. You've got too many other health problems. Yes, you are not taking care of yourself physiologically and mentally. There's no way I can get you through surgery safely. And they interpreted it all in different ways. But that's the toughest part of my day. And that's what wears me out the most at the end of the day. When I see 4 or 5 of those patients in the penalty box, I am exhausted mentally because just getting them to the point where they realize that there is no easy fix. Now, the other side is the patients that I can help. And as soon as that penalty box door opens, I'm on the ice and I'm skating and I'm doing what I need to do to get them better. We get the imaging, we verify the diagnosis, we optimize all their other medical and physiological issues. And then I sit there, and before I even get them to the operating room, I've already planned the surgery. I know exactly what I'm going to do. A, B, C, D, and E, how many different steps. And I have my plan A in place. I have my plan B in place and plan C. You always have to be prepared to call the audible. If plan A isn't going to work, I need a fallback. I want to take 1 or 2 steps forward without burning the bridge behind me where I can't retreat. So that's the work that we do when we decide, yes, I can fix that patient.
Excellent methodology. Really appreciate that. And I do find that the surgeons that I talk to are the ones who always have backup plans. And they also tend to be the surgeons who can fix their complications as well. Do you find that to be the case?
Absolutely. Regardless of the surgical specialty, you have to know how to get into trouble and how to get out of trouble. So you need to know what's going on. And this is where I really, really struggle with what's happening in medicine today. There's this dilution of medical specialties with this insatiable desire of other non-operative specialties getting into procedural specialties, like pain management doctors doing percutaneous fusions. That's wrong. That's absolutely wrong. They don't know how to get into trouble or how to get out of trouble. So it's just problematic right now in medicine. And we do have to be, and this is where the societies have to start coming together and deciding on the scope of practice. We're blurring the lines, and I truly feel this is detrimental to patient care in the future. You can't have an individual that's not trained in the basics of surgical technique, in the physiology of bone metabolism, in the concept of preoperative and postoperative rehab, doing spinal fusions. You just can't. It's wrong.
I agree. Well, Dr. Lieberman, so much information. I've learned a lot, which I knew I would. And I really appreciate your time. And thank you so much for the interview.
Great to meet you.